Good morning, everyone. You have on the screen Dr. Gray's bio. Dr. Gray is, for those of you in the Metro DC area, he's a movement disorder specialist affiliated with Integrated Neurology Services, which has several offices in the area. As you can see, he completed his residency and fellowship at Loma Linda University in Loma Linda, California. He was chief resident and was instrumental in resident didactics, educating other providers with lectures on strokes and seizures. And he has a breadth of experience caring for Parkinson's disease and understands that each individual requires a personalized approach to treatment. And I'm going to let Dr. Gray take it away.
All right, thanks a lot. Appreciate it for having me. And thanks so much to everyone who's here on a Saturday morning. Not where I'd be, but I'm here, so I'm happy to get the presentation. Um, and that was just a joke, of course. Let me go and share my slides. Okay, just let me know if there's any issue on your guys' end, but I can see the slide in front of me. So today, basically, we're going to talk about. I had some thoughts as well as the PSN has some thoughts about how we can reach out and educate patients about going into a mind of a specialist, right? So I don't expect people listening here to be able to manage someone else's Parkinson's disease when they're in the clinic in front of them, but I do hope that there'll be some takeaways, salient takeaway points that you'll be able to understand so that next time when you are going to your specialist or just on a day-to-day basis in your day-to-day life, you can kind of notice things that are important that look for how your condition's going on a day-to-day basis, but also over time. Because in training, from medical school all the way until through my movement disorder fellowship, we see patients and we're trained to ask a very specific set of questions. And they may seem sort of terse or cold or matter of fact, but every question we're asking, there's a reason behind every question. So it might seem sort of unrelated, or it might seem, why are you asking me that way? But there's always a reason we ask that. And that's in order to get to a place where we can synthesize what's going on from a diagnostic perspective, but also we can find a treatment plan. Even though we all receive more or less the same information in a classroom in medical school and residency and along the wards, what we take away from other physicians alongside us and patients is different. And our delivery is different with those patients too. So that's where I think there's a dichotomy between the patients out there who may feel like they're getting great care, which is I hope everyone does, versus patients who feel like maybe there's something missing, right? And some of that, of course, is the physician. A lot of it is the healthcare system in general. And then some of it also, I think, is by the patient maybe not being fully informed about what they should ask. And that's kind of where I come in here to try to help guide you guys. So Parkinson's disease is more than just your symptoms, right? So the specialists, again, we look for markers. We look for the bradykinesia, the tremors, the stiffness, the decreased arm swing, all that stuff, right? And then we say, based on the history, it sounds like it's Parkinson's. Great, right? But person A versus person B, it can be completely different subjective what they feel, right? Someone who might be an avid runner and then realize that they are a little stiffer in the shoulder. And so otherwise you look at them on the street and they're like, oh, they're totally normal. Like from even my perspective, I would say that. But for that person, they realize that there's something going on versus someone who may not notice those symptoms until it gets later and they're already kind of stooped over, they're shuffling, and then a lot of people can notice that there's something different, right? So we have a large variation in how it can present, how it can progress, and how it affects the patient, right? So whenever I see a patient, I take kind of inventory, the history of what's going on in the life, medication symptoms, et cetera. But I also ask, how is it most affecting you, right? If you have a horrible tremor, but you're still able to play the piano, the guitar, talk at the conferences, then my, aggressiveness to want to treat it is much lower than someone who has a tiny little tremor and a flicker in their finger and can't present at the office because, he or she is really nervous, right? So it's really subjective. A lot of it's very subjective, although we see objective things on the exam. So, we may lose what's important to the patient, right? So we focus on the tremors, the rigidity, but like what's important to you, right? I want to focus on that. So everything you should look into about this for yourself is what do you wish you could still do for yourself? Um, you're not there where you were before, but now you're starting to notice some change in your function because of a tremor or stiffness. But what do you wish you could still do? You wish you could still run. You wish you could still, do woodworking with your hands. If you didn't have Parkinson's disease, what would you do? And what's the most bothersome barrier? So those are really important things to keep in mind, even if the doctor doesn't ask about it, which they may not, to think about and bring it out, right? Because I always want patients to make sure that they have the questions answered and that they have what's important to them addressed, at least brought up, so we can start the ball rolling on how to improve that aspect of their life. So what's the problem? So there's just not enough time spent with patients in general, right? I mean, too many patients, too little time. We have these productivity numbers from a doctor's perspective. We got to see all these patients. It depends if you're outpatient clinic, in a hospital, et cetera. But it's a business, right? But um, I'm happy that where I am able to spend a lot of time with patients, even if it's just a routine follow-up. I feel like I get enough out of it. I feel like they get enough out of it. But at the end of the day, even if I have the exact diagnosis that you made and no one else made it, it doesn't really matter that much unless the doctor is able to explain what's going on in the patient. Because again, you could have this rare condition and the doctor's the only doctor that ever figured it out, but nothing's going to help unless the patient knows what to do with that information. So what's the job of the specialist, right? And this can be consistent with really any physician, but take a history, listen with intention, to know the subtleties of the Parkinson's disease and the mimics, perform a competent physical exam, summarize the diagnosis, form the treatment plan, and answer questions, right? So this would be great if it's all done. I try to do this every time I see a patient, even follow-up sometimes, right? Because there can be new things that come up, new symptoms, et cetera. But what actually happens is there's a history, there's frequent interruptions. The physical exam is very brief. You know, they may say, okay, you have Parkinson's. And it's like, what? I have Parkinson's. What? And they just kind of say that. This is sort of what was been relayed to me by other patients, and my heart goes out to them hearing that because it's not just you have a headache, you have a migraine, it's you have Parkinson's. So it's a life changing diagnosis, and I don't take that lightly at all. Um, and then you just say, take this medication. This is what you take, and again, it's sort of without any further information, just puts that out there. And then they may or may not answer questions. Again, this is just sort of the not necessarily the reality for everyone, but just sort of the synthesis, how I synthesize what's going on in our current medical system, and how I think there's definitely ways in which it can work. So the visit can be very brief, and then they might say, "See you in 6 months," right? So you get about 10 minutes. You go in with symptoms. You don't really get a full story, get your whole story out there. They might query you a little bit. They may interrupt you. They do a quick physical exam, and they say, "Here's the diagnosis, here's medication, see you in 6 months." So to me, that hurts just hearing that, because this is you're a human being. You deserve dignity. You deserve respect. Not that you're not respected, but physicians in general just need to do better time, I think, and healthcare providers better time at conveying what's important to the patient. Um, but anyway, this is sort of a symptom of our overall healthcare system, what's going on, and how things should be better. But luckily, I'm able to say this because I feel like I have two perspectives. I went to training and saw this, but now on the other side, I'm able to do these 6 points instead of these 5 points. So here's an overall guide for how you can get more out of your office visit with your specialist. So, and I'll go through all these. So being on versus off, don't get used to this. Master your medications, be wary of non-motor symptoms. Don't come to the clinic alone and disclose what really bothers you. So know what on and off. So this is probably the number one thing to know as a patient and a partner, a caregiver, et cetera. Because once you know this and I can articulate it, it makes managing the medication of the condition, disease state, much easier for me. So every time I see a patient, whether it's the first time or the fifth time, I'm always asking some variation of these questions, right? Because I want to know from the first dose to the second dose, do you feel pretty steady or do you feel like you're wearing off a little bit, and then I go into what is wearing off, and I even kind of reiterate that what is wearing off, right? Because again, wearing off for person A could be very different from person B, right? It's not just necessarily um, it's not necessarily the tremor. It could be a feeling inside. It could be something indescribable, but I want to know that so I can document it and then figure out in the future what to look for, but also help you understand what wearing um, off and on is, right? Because as I'll get to, it is a marker for the disease progression. So things to ask yourself. This is kind of what I asked too, but just good to keep in mind, when you're at home or doing your day-to-day things in life. So how do you feel before you take your next dose? How do you feel when you wake up before your AM dose? Are your symptoms steady throughout the day? Do you feel the medication kick in? If you miss the dose, how do you feel? And the other thing is that I teach other physicians as well. If the patient, if you don't have any more fluctuations, if you don't feel like you're on or off, you just feel the same, maybe because you're underdosed, because you're not getting enough. So therefore, you don't even perceive that fluctuation because you're not getting enough on, and you're more likely mostly off, right? So that's what I see as well. But that can take quite a bit of time from a specialist point of view to kind of dig that out, right? Um, and so, I pride myself in getting the information because with that information, you can make a big difference. That's the difference between changing medications or keeping it the same. And if you're only seeing the doctor every 3 to 6 months, that's quite a bit of time when you're kind of where you're supposedly at. So this is a really, really important graph. You've probably seen some variation of this. Basically, the blue squiggly line in the middle is the concentration in your brain or blood of the medication levodopa, carbidopa, levodopa, cinnamide, etc. Rytary, Crexont. These are the different variations of formulations. So you can see from the left, it's onto the these to the right, it's over 10-year time. So as time elapses, the dose, the medication levels when you measure them are unchanged. They're the same. You take a medication, it goes up, then it goes down, right? You take your next medication, goes up, down, etc. Right? So there's a thought that, well, the medication just doesn't work anymore. Over time, it just stops working. That's actually not true. It still works, but the window in which it's therapeutic, meaning in which you have good on time, meaning that you're walking normally, you don't have a tremor, you're not stumbling, your voice is louder. Um, that's on time, but good on time meaning you're not dyskinetic, you're not excessively moving back and forth. That window will close, and that window is that white space there. Initially, patient has a tremor, they take a medication, they're totally fine, right? Maybe for years. And then they start to notice, I feel like my friends tell me I can't catch up when I'm walking, with them on the daily walk, and I realize that I'm not swinging my right arm as much. So then it's like, okay, then we got to figure out how often you notice that, when in relation to the dose you notice that, et cetera. So that's where we have to be really good history takers, and for patients, really good history tellers and descriptors, so that we can further optimize your medication. And then, of course, same exact slide. I should say same exact graph, but now we're in the non-motor fluctuation, which is oftentimes missed, not just by the physician, family, but also the patient, right? So, who doesn't get, a bad mood once in a while? Who doesn't feel like they don't want to do things once in a while? Who doesn't feel like they can't think clearly? I mean, all these things happen, even in younger people, who don't have Parkinson's. So, um, but this is something that can be improved with dopamine, right? Dopamine is not just movement, it's cognition and it's mood. All three of those circuits are intertwined together. So therefore, over time, as the disease progresses, these symptoms can come about. So they can also be responsive to medication changes. So again, this is why we need to ask about this and you need to be aware about it. So here's one example. So it's Mr. Jones, 72-year-old male with a right arm tremor that started 3 years ago. So it hasn't bothered him, right? But in the last 3 months, he's lagging behind in his running group. He runs at 10 a.m., 3 hours after his first dose. So his medications are the carbidopa, levodopa, one tab 4 times a day, 7, 11, 3, and 7. So just as an aside, I always ask about, obviously the doses, the medication doses, and the time, right? That's very important to figure out your activities, right? If you tell me that that you're really, really active running, doing errands in the morning, but the afternoon not as much. For me, my approach to be more aggressive is going to be focused more on the morning, right? And again, that's a very nuanced discussion conversation with the patient and me, but I want to make sure that you're optimized for as long as possible. So basically, what are some decisions for the physician at this point? So you can increase the dose, right? So at this time, he has at 10 o'clock, he's having symptoms, right? This is wearing off, right? So lagging behind could be just slow, is stiff, coordination, etc. Um, so at 10 o'clock, which is 3 hours after his first dose, he's starting to notice some wearing off. So some things you can do is increase the dose, right? Increase the frequency. So increasing it to 1 to 5 times a day, change to extended release. Some of the brand names are there. Augment the dopamine with other medications, as you can see there, or given as needed a boost, right? So these are all approaches, and one might be right for someone, and then the other one might be right for the other person, or they might use more than two of these for an individual patient. So that's where diving into this, figuring out the problem, and then focusing on ameliorating it is very, very important. And this is where the patient-doctor communication is vital for that. So medications are individualized and may change often. Okay, so when if I see a patient and I'm going to go back to the tremor example, and they have a tremor, and they might be very distressed by the tremor, and I take that very seriously, right? But if I realize that, well, your tremor is actually, yeah, I can see it's pretty bad, but actually you don't really have much of the bradykinesia, the rigidity. That's actually better than it was last time. But if the tremor's worse, that might make me think that, maybe this isn't something we need to treat with, for example, carbidopa levodopa. It could be something else because carbidopa levodopa sometimes doesn't improve tremors as much as it does the rigidity and the bradykinesia. And so sometimes what can happen is that the patient can get on really, really high doses of carbidopa levodopa, only to see some minimal improvement or even no improvement in tremors. And now they're having more symptoms of, too much levodopa. So this is why, knowing how you feel, what's important to you, and what I'm seeing are right. So what I see objectively may not match up with your true perception, right? You might say, I feel fine. But then I realized, no, actually, you're definitely slower on your left side since last time. So even though you feel fine, which is great, your experience is extremely important, probably the most important. What I'm seeing is actually, no, it looks like you're having a little bit of wearing off. And so we need to probably potentially address that. So side effects in all Parkinson medications, right? And none of this is probably new to you. If you have Parkinson's, dizziness, GI upset, sleepiness, fatigue, hallucinations, maybe more in advance, dyskinesias in advance. So again, just a reiteration of what you probably already know. And then, of course, the assumption is that everyone here has Parkinson's, but the big thing that we pride ourselves on is in order to figure out if this is actually Parkinson's, you need to have a response from levodopa or carbidopa levodopa or Sinemet, et cetera. Because if you don't, then whatever's causing your slowness is likely not due to lack of dopamine, it's due to something else, right? And what I'm talking about is I'm talking about maybe Lewy body dementia or progressive supranuclear palsy or Parkinson's from a lot of strokes, all these things that can affect dopamine, but they don't respond as robustly as the quote unquote Parkinson's disease that we're referring to here. So key number two, don't get used to this. Remember your old self, right? So there's always ways in which we can improve your symptoms. Always, right? Even if you're end stage, God forbid, wheelchair, sometimes that will happen for some patients, of course, not necessarily only Parkinson's due to other conditions as well, orthopedic issues, etc. But there's always things you can do, literally always things. So what do you want to be able to do, right? Even if you haven't ran a marathon in a couple of years, hey, I mean, try to run a 5K. There's things we can do to try to achieve this. And it's important for the physicians to know that so that we can help address that. And no, it's not all due to your old age, right? There are people like this gentleman here on the right who's running still. And blame your medications, right? So So yes, your disease is progressing, right? But the medications are there to help you. And there's things that you can still make changes to that can further improve your physical status. Here's another example, the same patient. So he's Mr. Jones in the morning, 2 years after we first saw him, um, not having energy for running in the morning. He's tired in the morning and stiff. His wife reports his mood is down and he appears unmotivated. Okay, so this is not, you can't say this is 100% due to Parkinson's exclusively, right? There's other reasons why someone may have, you know, feel tired in the morning or stiff, etc., right? But this is his medication here. So he's on a longer acting carbidopa levodopa called Crexont. He's on tacopone, which is a kind of a booster medication. And he's running every morning, which is his baseline, right? But what's changed? Well, it could be that he has morning akinesia, meaning lack of movement or lack of starting movement, right? So, so again, this is just something that a doctor will look into, right? So you can add a nighttime dose of carbidopa levodopa. You can add another medication at nighttime to further extend the release, the action of the dopamine. Give an AM boost, so you wake up and give yourself inhalation of Inbrija or injection of Apican. If there's other reasons why he or she could have a difficulty sleeping, maybe that he's having a lot of the REM behavior for sleep disorder, the acting out the dreams. You can add melatonin to see if that helps as well. But also ask about depression and ask about sleep quality, right? Is there snoring? Is there sleep apnea? Again, all these things need to be, in my opinion, condensed into a visit and addressed, right? Because if not, we're just going to be treating the patient with medication, which is obviously very important and vital. Without it, it would be much more difficult to go about things. But it's not just medications, it's the simple things in life. How's your sleep? How's your stress? Are you drinking alcohol? Are you getting physical activity? Are you socializing with other people? All these things are very important. It can affect anyone's mood or even motivation if they're not there. So master your medications and always ask questions. So again, this is simple, but this can be confused sometimes. So know your doses and the timing, right? Take them at the same time if you can. Be mindful of the meals, right? And please tell us about side effects. I don't want anyone to hide the fact that they're uncomfortable taking something, right? Because therefore I'm going to believe that you're taking something, but then you say no, it's not working, and I'll say, oh, it's just an ineffective medication. But in reality, you're worried about the side effects, or you have side effects. So therefore, I'm not getting the clear picture, right? If I knew there were side effects, then there's ways that we can adjust that or change the way you take it, et cetera, or add something or take something away. But if I just hear that you're just not doing well on the medication, then I'll think, okay, well, the medication's not effective, right? But that's something that I'll ask about because otherwise I'm not going to know. And by you telling me about side effects, that again reinforces that you will understand that there may be side effects. And so we can kind of help try to prevent those or curb those in the future. And yeah, again, just tell me if you're not taking this directed. I'm not your mom, not your dad. I'm just your physician. So I have recommendations about treatment, but I'm certainly not the person that's forcing you to do so. So here's another example. Again, Mr. Jones, he's had the condition now for 10 years. So he's optimized his medication regimen. He's taking the medications as directed. He has a phone alarm, which is a great idea to alert him. He still feels that he may have sudden freezing episodes, even right after he feels the medication kicks in. And then sometimes medications don't seem to work, you know? So his medication regimen is now he's taking 4 capsules of Crexont instead of 3. He's taking Gocovri, which is an extended release amantadine a night. He's taking the tacopone, the dopamine booster. He's taking Nurigas, which is another medication. So what is he having? So this is called dose failure and sudden offs. Okay. So I'll just go to this real quick. So you can see in the bottom right that graph there with the different colors. Um, so the arrows are when you take the medication, right? So at the very far left, it says early morning off. So kind of like we said earlier, he wasn't motivated, he was kind of down and depressed. Well, he's not, the medication's not in there, right? It needs to be in the kind of the dark gray zone in order for it to be optimized. Takes the medication, but then about a little later, it finally starts to kick in, right? And then he gets off, around 11 o'clock. Um, and then the next dose around 1400, 1430, he doesn't get the same effect as he did. It didn't go as high. And then the dose failure, right? At 5 o'clock, 1700 takes medication, nothing happens, right? Now, this isn't necessarily really common. However, it can happen, right? And there's a lot of factors why that could be. So, why could that be? Well, what happens when you take a medication? So, you have to swallow it, you have to digest it, it goes to your stomach. There's acid in the stomach that depends on, what's in there, what food's in there, if you drank something for fasting, and then it goes to your small intestine, it gets absorbed. Well, are you taking other medications, supplements? Are you constipated? Do you have gastroparesis, slowness of the GI tract? All these things can impact the medication. Then the medication goes in, but it has to compete with other things like amino acids in order to get into the body, the blood, through the intestine. And then it has to do the same thing and compete with other proteins as it goes to the brain. So all these steps, miraculously, it actually gets where it's supposed to be. So that's why, meal timing is important as well as, your stool, like getting regular, going to the bathroom regularly, right? So these are just some tips, right? Now the newer medications, including the infusion pumps, which recently came out, Vyalev and Napco, these are the two medications that completely bypass all that, right? Yes, they still go to the brain, but there's no absorption through the GI tract. There's nothing to do with absorption, swallowing, digestion. It all goes through the skin capillaries and then eventually the blood and the brain. So that's something that I think, in my opinion, this is a different topic. In my opinion, I think that is a game changer, has been a game changer, and will be the game changer. I would think probably honestly the more the standard of care in the coming years, because in order to make sure someone's on the whole time, this upper graph, this large, large gray triangle shape, that's where I want patients to be indefinitely. I know it's not possible indefinitely, but if people can stay on that line as long as possible and have as little too much dyskinesia and as little off time as possible, then that's what we want to achieve. And the infusion pumps are as close to that as possible because they deliver a consistent dose. And then be wary and mindful of non-motor symptoms, right? So now Mr. Jones is 85. His walking's fine. He has no tremors. Great, great. So from a movement disorder perspective, you'd say his movements are great, right? And dyskinesia, okay, he's got some dyskinesia, but that means the medication's working, right? He's on, he's not off. And for him, then I even bother him. Great, my job's done. No, actually, no, it's not done because he's fallen down twice and he's been feeling a lightheaded, right? And he states he goes to the bathroom 5 times a day. So number one, great. His motor symptoms are on. That's amazing. But he's falling, right? It doesn't matter how controlled someone's tremor is if they're falling down, right? Because a fall in someone who's 85 can increase mortality significantly. And then they're going to the bathroom 5 times every night. So they're not getting sleep, right? They're just not getting sleep. So frequent urination and orthostatic hypotension, which is when blood pressure drops when you stand up, all these things can be pretty prevalent and pervasive in Parkinson's. So fainting and low blood pressure can be a result of advancing Parkinson's and medication. So this is where the medication management needs to be on the ball, because there will have to be adjustments on medications or potentially adding medications. So definitely, we love when we see objective data. We love when we see blood pressure numbers. I know it's not easy to check blood pressure more than a few times a day necessarily because our labs are busy, but it's very, very important to get an accurate look into what's going on. When you come to the office to get the blood pressure, that's one snapshot. But when we get it over time, 1, 2, 3, 4 times a day, we have a lot more information, and that's helpful for you and for us, right? And these are some other things that can potentially help orthostatic hypotension. And then again, mood and cognitive changes, right? So the burden of non-motor symptoms, those become more burdensome and more challenging for not just the patient, but the caregivers as well. No one wants to see someone's mind going. No one wants to see someone not being as they once did, as they once behaved. But at one point they'll be less independent than they will for a lot of patients, not everyone, and they're going to have more supervision. So that takes away from their independence. They might want to drive a car. Now they might not be able to drive a car for safety reasons, medical reasons. And so they'll be a little bit upset. They can't go to the grocery store by themselves. However, if they did do that, great, they'd be independent, but then they'd get in a car accident, right? Or they'd get lost, right? So therefore, it requires the caregiver or someone there, a family member, to be by them more frequently. And of course, you know, that affects the caregiver because then their life is starting to be affected and consumed by what's going on with their husband or wife or person that has Parkinson's, right? So it does definitely present an issue, and it's definitely important to bring this up to the physician as well. Bring a family member or friend, yes, definitely important. See, getting another perspective is always helpful. I can't tell you the number of times that I'll ask a patient with the wife or husband there next to them, and I ask them, how are your symptoms? Are you falling at all? How's your memory? And he or she will say, "This is great." And then at the same time, before my eye, I can see the caregiver or the wife or spouse just shaking their head, like, no, they're not fine, right? And so that's very valuable, right? I still, no matter if the patient's demented or not, I I still take the patient's perspective into account because that's their experience. But having the spouse there is extremely important too. For example, the spouse will say her Parkinson's is advancing because his tremors never stop. The patient says, "I'm not bothered by tremors." So that's where the doctor can say, "Okay, so we have the tremors and we have the worry that the Parkinson's is advancing." So the reality is that tremors don't always correlate with the disease progression, right? So that's where we can kind of take the anxiety out of the severity of the patient's symptoms by the time at the same time reassuring the spouse or the wife, etc., that things are going to be okay, or not as concerned, right? And so this is all very helpful. This can all calm a lot of anxieties and just make for a better interaction and outcome for the patient. And caregivers carry the load, right? So it's as much the patient's disease as is the caregivers, right? And that's why they have the PSN, they have a lot of other support groups, organizations, all the stuff out there that you should definitely ask your specialist about, right? Because um, the specialist may not have Parkinson's disease, they probably don't, or know someone personally that has it, in a family member, but there are things that you can teach the specialist as well, like, oh, by the way, I went to this event and I did big therapy, or oh, hey, I recommend this, and that's important too, right? Because then the specialist can spread the word. So I always love hearing what patients have to say and kind of taking their advice about what's been helpful for them, but also just knowing this can be very, very empowering for improving quality of life overall. And that's everything.
Great, Dr. Gray. We have a few questions in the chat. So
Yeah,
if you're ready, do you want to stop? Well, we'll leave that up for a little bit so people can get your contact info. But
sure. Yeah, you can. Yeah, no problem.
so the first question is, do you prescribe ropinirole? Why and when?
So good question. Yeah. So again, it totally depends on the patient, right? So ropinirole is a very good medication. It stimulates dopamine. Um, so the medication ropinirole, yes, I do prescribe it, especially for things like restless leg syndrome, more commonly probably. But um, I usually prescribe it usually earlier on in the condition, and the reason that is because it's potent, right? So it's very effective, but it has a higher incidence of side effects, and it's not as tolerable as carbidopa levodopa, meaning more nausea, more lightheadedness, swelling of the legs, and then as patients get older, it can cause more problems, lower blood pressure, falls, hallucinations, right? So there are some things to keep in mind about it that I think about when I prescribe it or don't prescribe it, or if someone has it. I have many patients who are on the medication along with Cinemet, um, and I want to try and reduce the dose of the ropinirole because the Cinemet usually is better tolerated, and just a better medication overall for motor symptoms and non-motor symptoms. But yes, ropinirole does have a place in my repertoire.
We have an additional question. I'm not sure if you addressed this in a presentation, but it says, can you address the use of Ritari versus Crexont to minimize off time?
Yeah. So they're both good medications, right? And so the idea is that they last longer than the traditional Cinemet. Um, so I use both of them. Crexont just came out almost a year ago now, and it's kind of like a super bacteria, right? So it actually lasts longer, and it has a different way in which it kind of gets absorbed. Um, so yeah, I frequently do use those. I frequently will switch patients from the Cinemet to that. The one thing about the changing over to those medications is that it's not a one-to-one conversion, meaning a 2500 tablet is not there's not a 2500 Rytary or Crexont, right? So uh, there's a suggested dose conversion, but I always tell patients it might be a little bit until we get to the optimized dose, right? So that's one thing. There might be a couple of bumps in the road, but overall, patients I found that do better because mainly the wearing off is less.
There's a follow-up question that just came in. What do you what have you heard about patients' experience with the new drug Crexont?
Generally, it's two things, right? Granted, it hasn't been out very long, right? So we're still getting data, real world data. But two things. One is that it's better, right? So it's like, no, I only take it 3 times a day, so 4 times a day, and it's like I feel better. I feel like I don't have that wearing off, right? Kind of what you hope to hear. The other aspect I hear it's too much for me. It's I feel dizzy, I feel lightheaded, I feel giddy, I feel like overdosing. That's sort of kind of the words I've heard. And my theory is because again, they have a suggestion conversion, right, from one tablet of carbidopa to one tablet of Crexont, et cetera. Um, but it's not exact. It's not exact conversion per se. And then the higher the doses you get, if someone's on 5, 6 pills a day versus 3 pills a day, it might still not be the effect might be larger over time. As far as if there's a small difference, it'll kind of accelerate and get larger. So that's kind of where again you can either start on the lower side as a physician, be more cautious, or be more on the aggressive side, and that really depends on the physician and the patient and everything else.
Our next one is there's an art to unveiling a diagnosis of Parkinson's disease. I hear the use of chronic, degenerative, and progressive with no cure. Where is the upside for hope in this prognosis? Programming the patient for a negative future can have repercussions. Dr. Gray, have a unique and positive outlook. In a wordy way, how do you tell a newly diagnosed patient, and what do you advise them to do?
Yeah, so that's a very, very good question. Yeah, and it really, really does matter how one frames it, right? Someone with ALS, this person and this person, right? I mean, granted, let's just say hypothetically they're going to have the same license for 6 months, right? So that's dismal, right? On paper, dismal. No one wants to hear that. It doesn't matter how old they are, how young they are, whatever, right? But it really, really matters how you put it, right? And that's true with anyone, right? Anyone in any walk of life. If you lose all your money, you can say, I'm going to go broke, I'm going to be on the street, which would be true. Someone else say, well, I'm going to get a job, for example, right? That's a very crude example. But how I say it is when I see a patient and I'm thinking they have Parkinson's, I do the whole history of the physical exam, and I'm like, yeah, I think of myself, think of this as Parkinson's. So what I'll do is inside my head, I take a deep breath and I tell them, this is what I'm seeing on your exam. So I explain to them what I'm seeing. I see the bradykinesia, and I use easy to understand words. I don't use technical words. Or I see slowness of movement, your dexterity's off, you've had this for a couple of years, et cetera. So I'll kind of recap what has been told to me, put that with my physical exam, and therefore the patient understands that I've listened to them and I've kind of processed this, right? And I'm synthesizing everything, right? So that I think it helps that they are heard, right? And the physician in front of them understands what they're going through. And then I say, this is most likely consistent with, for example, Parkinson's, right? And I try to have them think about or ask questions, right? Because I don't want to just overload them with things, because you can start looking up things and asking more questions. But I try to have patients stop think about it and ask me questions. If not, I'll keep going. Um, and what I do is I focus on the fact that there's so much treatment. There's just so much treatment out there, right? And if Parkinson's is managed correctly, meaning with all the tools out there, not just medications, but non-medication, physical therapy, et cetera, lifestyle, then there can be a very good outcome. Now, are you going to be back to how you were before Parkinson's? Probably not. But that's why we have to work together for this, right? Someone who has a new chronic disease, yes, they have a new chronic disease, but they have a chance to make their life better, right? On paper, it may not be as better, good. They're going to be not walking as fast, et cetera, but they can still make changes that they wouldn't have done without the condition, if that makes sense, right? So they can kind of make this a positive swing, right? So that's what I tell patients, right? That's what I tell patients, and I offer that they contact me because I know how hard it is to get in touch with doctors, including myself. When I'm a doctor, get in touch with a doctor. So that's another thing too, right? It's like they kind of feel like they're on an island, right? So I always encourage them to ask questions and to clarify, and I'll help clarify things. And it doesn't matter on the surface of what the patient looks like. If they're slow, if they're tremoring, if they look like they're quote unquote normal. I always ask how they're feeling because that is just as important as what their motor symptoms are like.
Great answer. The next one is I know this is a managing medications presentation, but what non-medication treatments do you find most effective in managing symptoms?
So I always talk about lifestyle, right? I talk about sleep, right? I ask about the sleep because, you know, if you're in pain, if you're stiff, if you're wearing off, well, how's your sleep? And then, okay, I sleep 8 hours, great. How do you feel when you wake up? I don't really feel good. Okay, so the time of your sleep is kind of irrelevant, right? It's really more the quality. And then you look at, is it because you're waking up a lot? Is it because you're acting out your dreams? Is it because you have insomnia, anxiety, pain? All these things can be looked at and addressed, right? But other than sleep, it's exercise, right? I find that, and the studies bear this out, patients who are more physically active tend to have a better prognosis, right? Because, I'll see someone who's in their 80s and has Parkinson's, right? And they've had it for 10, 20 years. And I'm like, wow, 10, 20 years and you're only taking this amount of medication. It's amazing that you only have this small amount of medication, but the patient's also very active. Like they might be more active than me. Where some other patients, sadly may not be as active for whatever reason, nothing against them. And they're dealing with other health conditions, right? So by doing more physical activity, resistance training or cardiovascular, or just being active in the community with other people, stimulating cognitively themselves, the rest of their health is going to get better too, right? So that's why I said we can't just simplify this Parkinson's to tremors, bradykinesia, rigidity, postural stability. We need to look at the whole person, right? So that's why physical activity is very important. And that's why I mentioned patients that should look into the big therapy. Even if they have a little tremor on the right side and they're all those fine. Getting those principles, in their back pocket as early as possible is very important so that they can use that blueprint moving forward to improve their life.
Our next question is I've tried Cinnamon and Resegeline. They both knock me out. Is that common? My symptoms are mild. Do you think I'm overdosing?
Again, can't specifically speak to your disease state and case, but yeah. So the Cinnamon and Resegeline, they can potentially produce symptoms of fatigue or dizziness or just these sort of symptoms that I kind of hear that kind of feeling that you're knocked out, right? And it's also again important to talk about this with your physician and look at the symptoms, right? So, for example, like if someone's on this medication, yes, they have Parkinson's, I presume, but do they really need to be on this medication or that dose of medication, right? So there's certain medications, in my opinion, and I always elicit and ask the patient how they feel since they've been on it. They can tell me, right? Rasagiline, Selegiline, Nuriance, these are medications that are compared to real carbidopa levodopa Cinnamon, not really effective, right? And so I usually seldom prescribe them. And so therefore, if they're having certain symptoms like that make me think that maybe they had a relatively higher dose of what they should be on, then I usually take those medications off, right? And obviously, always talk to your physician about that. But that's sort of what I would say, is that I tell patients, this is sort of outside of the Parkinson's cohort, right? But I tell patients when I see them for headaches or pain, I'm like, if I can get away with avoiding prescribing medications or avoiding ordering tests, I'll definitely do it, right? We don't always have to order tests or give medications. We can just counsel, right? Doctor means to teach. So we can just counsel and advise. Um, that, in my opinion, is better medicine than medication. Of course, medication is vital, but doing that and having the connection is just as important.
Next one is neither levodopa nor carbidopa seem to be working for me anymore. Is there something else I can take? I feel that no matter what I tell the doctor, I think, or the neurologist, all the neurologist here is levodopa carbidopa.
Yeah, so there's a whole panoply of medications. And there's medications, there's ways that for every given medication, there's different ways you can take the medication, right? Half tablets, changing the times, looking at again, okay, you're on this medication, figuring out if it works or not. If it's not working, why? What's the schedule of eating, what's your exercise, like looking at everything, not just the actual pills, but how the pills are getting into your body, right? So as far as the gold standard medication, right, is the carbidopa levodopa. That's you get the biggest bang for your buck. And that's why I usually start on that medication for most patients. But figuring out, what are the main symptoms that need to be treated. That's important, right? Because if we just say, now you have Parkinson's, so everything is Parkinson's now, let's just treat with Sinemet or carbidopa levodopa riterexon. It's like, okay, well, again, we need to kind of revise our expectations of what we're treating, right? So again, that's where you go back to the patient and ask them what's going on, what's bothering, right? There might be some non-motor things going on, for example, right? Or things like sleep, exercise, all these things, right? But yes, for example, for someone who's been on, carbidopa levodopa, they're on optimal dose, their symptoms are responding, but there's still things left that need to be improved. Then, well, maybe that's something like wearing off, right? So, or not optimal dosing, right? Or you're not able to tolerate it well. So therefore, you can think about hypothetically a different delivery system, right? They have infusions now, or they have the brain stimulation, right? Or someone with tremors, really, really bad tremors, they have the focus ultrasound, right? So there's different ways we can do it. So you can't speak to your specific case, but there's a lot of ways in which every day I see this, right? It's not. I would love for the medication to work perfectly, but oftentimes that's not the case, and I have to kind of go through why that's the case. So every patient, even at each visit, can be very, very different.
Thank you, Dr. Gray. The next question is, it sounds like your focus will be on movement issues, but if you have any information to share on the treatments for hallucinations or psychosis, I would be very interested.
Yeah, so a lot of that, before I address specific medications for that, a lot of that could potentially be addressed or modulated with looking at the dosing of the dopamine medication. So carbidopa levodopa, ropinirole, pramipexole, rasagiline, etc. All these things can cause hallucinations. All of them. Every single medication that enhanced dopamine can cause psychosis, hallucinations, delusions, paranoia, all these things, right? And of course, it really depends on the individual person, their disease state, what else is going on. Do they have an infection? Are they dehydrated? Low blood pressure? All this stuff can affect that, right? But specifically, the medication that is FDA approved now for Parkinson's disease, psychosis again includes those symptoms I mentioned, is Nuplazid, which is pimavanserin. It's a medication that is technically an antipsychotic, right? So it controls the psychosis symptoms, and it is pretty effective. It is pretty effective, I think, and it works differently than the other traditional antipsychotics. But usually, what most doctors will start with, both for insurance reasons, but also for comfort the fact that it's been a longer time is quetiapine um, or Seroquel. The other one that could be useful sometimes is donepezil or Aricept. That medication is usually used for memory, like in Alzheimer's, for example, but it can also be effective for hallucinations.
Uh, our next one, Dr. Gray, is this person is interested in nutrition and supplements. Do you have any advice for that?
So yeah, I think everything, all health starts with the gut, right? You are what you eat. And so there's a lot of data out there on nutrition and Parkinson's. For example, they didn't do a big clinical study on it because you can't patent a vitamin. But there was a rheumatoid specialist in Italy, forgetting the name right now, but he had a lot of experience with prescribing vitamin B1 or thiamine. They actually have a vitamin B1 book on Parkinson's on Amazon. Um, and there's thought that it can significantly improve the motor symptoms of Parkinson's, right? And it's vitamin B1. So, the B vitamins are water soluble, meaning that they don't accumulate like other vitamins do, like vitamin A, vitamin D. Those things can accumulate toxically potentially. So the B vitamins usually are safe. Um, so B1 or thiamine is something that has been shown in some studies to be helpful. Um, and what I say when patients say, "Is it okay to take this supplement?" Et cetera, I always say two things. One, if you think it helps, there's no clinical study or lack of study that will tell me that you should take it, right? If it helps you, it helps you, right? So I would say usually keep taking it. However, I also say that because they're not FDA regulated, unless they have third party testing like NSF or something like some kind of seal on there, then you don't actually know what you're getting, right? It might say vitamin D 5,000 international units or 125 micrograms, but hypothetically, and I can't prove this, they've done studies on certain supplements, there might be something else in it, right? Melatonin is a really good example of that. Melatonin over the counter, right? It might say melatonin 3 milligrams. There have been studies where it could be a fraction of that or much, much more than 3 milligrams. And furthermore, it might have other chemicals within it, right? Because it's not regulated or under quality control, you hope that that wouldn't be the case, but that happens, right? So there are certain brands that you can look up that are actually have third party testing. And so therefore, they have a higher standard and they're more stringent on the quality of their supplements. So that's something to look into too. Nutrition again, I wouldn't say there's a specific protocol or thing you should or shouldn't eat, but in general, if we want to optimize our physical health, cardiovascular, brain health, everything health, right? It would be trying to incorporate as much plants as possible, right? Legumes, beans, um, lentils, nuts, seeds, fruits, vegetables, all that has the phytonutrients, phytochemicals within it that have the naturally occurring vitamins and minerals. So you don't really have to take extra, oftentimes extra vitamins to get that. It's already in the food, right? Whereas, saturated fats have more inflammatory effect on the body, red meats, chicken, etc. And so try to eat that a little bit less if you can. And of course, as we all know, try to minimize processed food.
And one last one that was submitted, Dr. Gray, is do you suggest complementary therapies before deep brain stimulation, DBS?
I assume complementary therapies, I assume that means medications. Yeah, so you definitely need to try medications, of course, because you need to make sure one of your Parkinson's you're responding to medication, right? So DBS is a very, very good therapy, and I think oftentimes it's thought as like last resort, right? And of course, you don't want to do surgery if you don't have to, right? But you also don't want to have the patient suffer for so long on medications and not get something that actually works, right? So usually about 3 years out is kind of when the patient can be eligible if they try medications, if they have motor fluctuations or not able to tolerate the therapy. That's kind of when the decision can be discussed about deep brain stimulation. So there's definitely a time and a place for it. It's extremely effective. Um, And once you're on it, depending on where it's located in your brain, you can actually reduce the dose of the medication. So definitely an advocate for it. I have some patients on it, and it's definitely a good therapy.
So that's the end of all the submitted questions. Dr. Gray, I'm gonna allow everybody to unmute themselves if somebody had a question that they weren't able to put in the chat. So uh, does anybody have any questions? I'm not seeing anybody waving frantically, Dr. Gray. So I don't know, but I did ask everybody if they wanted to unmute to go ahead and unmute themselves. They should be able to unmute themselves. Yeah.
Yeah, I think most folks are still muted, so
Yeah.
I guess that means they've had
I
their
guess that means they don't have any other questions.
I'll
Carl, go
ask.
ahead.
That's great. I've asked this to a lot of doctors actually. And I'm always wondering what their answer is. Do you see a trend, a protocol for not a protocol, a profile for people with Parkinson's with your patients? Anything that is um, common with all your patients?
As far as like their symptoms or
Whether anxiety or stress or um, um, anything that resonates with each patient you see.
yeah, it's a good question. I think um, I would say that yeah, there definitely is a large level of anxiety, and anxiety is can be mimicked by so many different symptoms, right? But I think that's why when I see patients in the clinic is other than the motor symptoms and how they're doing, their off time, et cetera, I do kind of try to elicit what their level of comfort is and what their um, level of yeah, the level of comfort, right? So I can kind of get a sense as a physician, you see a lot of patients and you walk in the room and you can kind of sense where they're at. Are they really happy and hey, how's it going? Or are they there's something kind of eating away at them? And that's kind of why I asked what else is going on and keep pushing. What else? What else? What else? Tell me how you're feeling, right? Because again, it's not just about the medications, it could be other things, even not even Parkinson related, right? And I want to know that because then I can help address it. So that can play a big role. And I always try to look into that as a physician.
I would say Parkinson's is about 68% stress, anxiety. If you can lower the stress and anxiety, your symptoms get better.
Exactly, yeah, and that's why I look at nutrition, exercise, and sleep, right? Because I always say anxiety can make anything worse, right? It's just how it works, right? The brain and the body is all connected, and so if you can look at that, at least if you can just name it and recognize it, and have the patient kind of express themselves, that alone can reduce the stress.
Thank you.
Well, I think we are just a little over our 11 o'clock cutoff, but thank you so much, Dr. Gray.
Yeah, you're welcome.
So much great information and empowerment and hope in your presentation and your approach to treating and working with your patients. So greatly appreciate you sharing that with us today.
Yeah, absolutely. Thank you so
thank
much
you
for
so
bringing me on.
much.
And
Please come back and see us.
yes, absolutely.
Yeah, I'd be happy to anytime.
Well, I think that'll do it for us today, David. We're all done, and thank you all.